Good evening, ladies and gentlemen. I'm Andrew Samwick, the director of the Rockefeller Center here at Dartmouth. It is my pleasure to welcome you to this evening's Brooks Family Lecture on Universal Healthcare, to be presented by Dr. Mark McClellan. The Brooks Family Lecture Series was established in 1990 by Dexter Brooks of Westport, Connecticut. Mr. Brooks graduated from Dartmouth in 1947 and the Amos Tuck School of Business in 1949. The Brooks Family Lecture Fund enables the Rockefeller Center to bring distinguished guests to campus to foster a balanced discussion of national and international issues. This evening's lecture is also the first in a series designed to commemorate the political and policy legacy of Nelson A. Rockefeller in the year that marks the 100th anniversary of his birth and the 25th anniversary of this center named in his honor. Nelson Rockefeller was a member of the class of 1930 and became one of the leading political figures of his era. His distinguished career in public service began with appointed positions in both the Truman and the Eisenhower administrations. Feeling the need to have an election mandate behind him to get anything done, he left the federal government in 1956 and ran for governor of New York in 1958. He served as governor for 14 years before serving as vice president under Gerald Ford. It was in his capacity as governor that Nelson Rockefeller made his mark in a number of policy areas that are still very relevant today and that will be featured in this centennial lecture series. On the subject of healthcare, and in particular, tonight's subject of universal healthcare, he was truly a pioneer. The following is an excerpt from Joe Persico's 1982 biography of Nelson Rockefeller, appropriately titled The Imperial Rockefeller. This passage comes after a passage on his very conservative approach to welfare reform. Nelson Rockefeller was indisputably liberal on one issue, healthcare. The closest America has yet come to socialized medicine occurred briefly in New York State during his tenure as governor. In 1966, the federal government passed legislation providing medical assistance to the poor. Rockefeller seized upon the federal plan and then set a generous standard, so generous that 1 in every 4 New Yorkers was eligible for free medical care. A headline writer called the New York program Medicaid, and Washington lawmakers began to wonder what they had wrought. Rockefeller never tired of telling of a frantic call from Senator Jacob Javits. "My God, Nelson, at the rate you're going, New York State will use up all the Medicaid money that Congress appropriated for the whole country." Later, reluctantly, Nelson was forced to back down. With federal aid reduced, he had to drop more than 1 million New Yorkers formerly eligible for free medical care. He then tried for 5 years in a row to promote a state system of universal health insurance, but state business interests, fearing the cost of such a program, killed the bill every year. He was one of the few major American politicians and a rare Republican to declare access to good health care ought to be regarded as a basic human right. These were ideas that he had pioneered as the first undersecretary of the Department of Health, Education, and Welfare over a decade earlier, and that he continued to press through leadership in the National Governors Association. In doing my background research for this centennial series, I came across the following description of his plan from the May 11, 1970 issue of Time magazine. First proposed to the New York legislature in 1967, but pigeonholed in committee ever since. Recently resubmitted in modified form, with a companion bill to encourage the formation of group practices. Would establish a set minimum benefits to be bought from insurers. 1. 90 days of in-hospital, including psychiatric care in a semi-private room. 2. Outpatient X-ray, diagnostic, and other laboratory services, emergency care and minor surgery, physical therapy, and psychiatric evaluation. 3. Hospital or physician maternity benefits up to $150. 4. Hospital managed or other sponsored home care up to 100 visits a year. Patients would pay $2 in co-insurance for virtually all doctors, clinic, and lab services. The state would pay the premiums for all with incomes under $5,000 a year, split premiums in the $5,000 to $6,000 range, while those earning more than $6,000 would pay their own. To understand these numbers, $1 in 1970 is equal to about $5.34 today. So now we know where that $10 copay must have come from. I suppose it is very interesting some 38 years later to see what has changed and what has not in the national debate about universal health care. Tonight, we are pleased to welcome one of the nation's foremost authorities on health care policy. Dr. Mark McClellan is a senior fellow, the Leonard D. Schaefer Chair in Health Policy Studies, and the director of the Engelberg Center for Healthcare Reform at the Brookings Institution. In that capacity, he oversees the study of ways to provide practical solutions for access, quality, and financing challenges facing the U.S. healthcare system. He also co-directs an initiative to link the population-based research programs at Brookings with those of the Dartmouth Institute of Healthcare Policy and Clinical Practice. Dr. McClellan has a highly distinguished record in public service and in academic research. He was the administrator for the Centers for Medicare and Medicaid Services from 2004 to 2006, the commissioner of the Food and Drug Administration from 2002 to 2004, and a member of the President's Council of Economic Advisors and senior director for healthcare policy at the White House from 2001 to 2002. In these positions, he developed and implemented major reforms in health policy. He also served in the Clinton administration as a Deputy Assistant Secretary of the Treasury for Economic Policy from 1998 to 1999, supervising economic analysis and policy development on a range of domestic policy issues. During his government service, he was on leave from his positions as Associate Professor of Economics and Associate Professor of Medicine at Stanford University, where he directed Stanford's program on health outcomes research. Ladies and gentlemen, please join me in welcoming Dr. Mark McClellan.
Thanks, Andrew. That's quite an introduction. Thank you. Andrew, thanks very much for that introduction, and good evening to all of you, and happy Valentine's Day. For the students here, how many of you are here on a date? How many of you are here because you couldn't get a date? Yeah, I see some hands going up. That's okay. I won't take it personally. And actually, it is a real privilege to be here, and it's a special honor that you all did come out to hear from me this evening. Andrew didn't mention it, but he and I, and actually many of his colleagues at Dartmouth on the faculty here, and I go way back. Andrew and I were office mates together when we were in graduate school in economics together some years ago. I think Andrew was about 13 at the time. And who would have thought that just these many years later we'd be here doing the Brooks Family Lecture for here at the Rockefeller Center. As Andrew told you, there is a great tradition from Governor and Senator Rockefeller himself and onward through the activities here at the center in focusing on important public policy issues, including universal health care in particular, and it's a real privilege for me to be a part of that. Dartmouth has a great tradition more generally, in the medical college as well, for making a difference and understanding what health policies are working and aren't working in this country. Andrew talked about my affiliation now with Brookings after leaving government, but I'm also spending a lot of time collaborating with some of the leading academic researchers in the country on health policy issues, and many of those researchers are right here at Dartmouth. So this is a very special place to be talking about such an important topic of universal health care. This challenge of universal health care, which is the title of the talk tonight, is typical of the way that the public debate about the issues of health care policy are discussed. Typically, what we do is have a debate about how and whether we should get to universal coverage, universal health insurance coverage, which, as you all know, is not the same thing as universal access to high quality, affordable, and innovative care at a cost that this nation can sustain. There's an important difference between the two, universal high-quality health care access and universal health insurance coverage, and I want to talk about that tonight. I want to talk tonight about not just expanding access to health insurance coverage, important as that is, but about achieving real health care reform, getting to this bottom line result of high-quality, innovative care for all Americans. And what I want to highlight is that this is going to take more than just coverage reform. Simply trying to buy more people into anything like our current healthcare system and current health insurance system that is too expensive and, more importantly, falls short on delivering high-quality care and improving health nearly as much as it could. Simply trying to do that is not going to be sufficient. It's not going to lead to sustainable healthcare reform. So I want to talk tonight about real healthcare reform that gets to quality, efficient healthcare for everyone in this country. And in healthcare, perhaps more than in any other part of our economy, it's important to think about innovation as well. That's another theme I'm going to keep coming back to, innovation. About improvements in knowledge, about what works to keep us healthier, about improvements in medical treatments, medical technologies, and improvements in understanding how to use this knowledge and these treatments to help people stay healthier, to rightfully give us the expectation that healthcare and health tomorrow is going to be better than it was today. For all the shortcomings that our healthcare system has, and you've experienced many of them, the achievements, if you look at just the overall statistics that have resulted from progress in biomedical sciences, are actually very impressive, and that's why I'm so focused on innovation. If you look back over the last 50 years, the mortality rates from cardiovascular disease have declined by more than 60%, and those rates are continuing to go down. In recent years, we've seen reductions in the mortality rates for many common cancers. Over the last 20 years, HIV/AIDS has gone from a death sentence to, for many people, a chronic illness that you can live with year after year after year. And for many of the other debilitating medical conditions, arthritis, other types of health problems that may not be fatal, autoimmune diseases, we've seen real progress in biomedical science that has led to significant improvements and measurable improvements in the quality of life of millions of Americans. In fact, there have been a number of economists who don't specialize in healthcare, macroeconomists, who look at the big overall economic picture, who have looked at what's happened in this country in terms of increases in healthcare spending, which have been substantial. They've been running a couple, 3% ahead of the growth rate in the economy for now 50 years and counting, and looked also at the improvements in health that we've seen in this country. And according to all these studies, which are by Nobel Prize-winning economists like Gary Becker and Bob Topel at Chicago, and Bill Nordhaus at Yale, David Cutler at Harvard, one of my collaborators, the conclusion is that while we're spending a lot more than we used to on healthcare, not only has this spending been worth it in terms of the improvements in life expectancy and the improvements in quality of life that have taken place in this country, in fact, the increases in productivity is reflected in the value of longer, healthier lives is worth more than all the improvements in productivity in every other sector of our economy over the last 50 years combined. So yes, iPods, jet travel, all that stuff is great, but what's really great is having more time to enjoy it. And not only to enjoy those things, but more time to enjoy your family and friends and sunsets and the nice snow out here at Dartmouth. So although we've seen some tremendous improvements over the last 50 years, if you look at biomedical science, we're really poised for potentially even more significant progress in the years ahead. If you think about it, new sciences like genomics and nanotechnology and stem cell technologies and good applications of health information technology. These are things that people are talking about, that you read about in the headlines, but that haven't actually had much of an impact on medical care yet. The potential is there for healthcare that's going to be even better, that's going to do a much better job of preventing and preempting diseases and their complications, that's going to do a much better job of tailoring its capabilities to your healthcare needs, to your preferences, to help you live even longer and better, an even longer and better life. But if you take a step back again and look at the public reaction to all of this, what's the reaction? Is it optimism? Are people pleased that we've got such a great and positive progress in our medical technologies? Well, not exactly, right? I mean, many of you have seen how much of, with the primary that was through here earlier this year and everything, you've seen how much concern, how much anxiety, how much anger there is about healthcare in this country today. And it's anger that, even if these better treatments are coming along, even the treatments that are available today, people are worried that they won't be able to take advantage of them because they can't afford it. This is a leading domestic policy concern heading into the 2008 election. And as those of us who have been involved in health policy know, and as you all probably know as well, when we can't find any more effective ways to these problems of rising costs and these problems of getting access to quality care, one of the things that tends to happen in government policy making is short-term efforts to try to keep costs down. And these short-term efforts can focus in areas like price controls or restricting access to new technologies or even rationing care. In fact, this is front and center in Washington right now. In the Medicare program, the statute that determines what doctors are paid every year has built into it an automatic formula that basically works like this. If costs go up, the payment rates of the doctors go down. That's written into the statute. And so what we keep seeing is efforts by Congress and efforts by physicians to try to head off these automatic spending reductions that are just built into the law. And Medicare as well is behind on covering new types of care, preventive care, electronic health care, and until recently, until just a few years ago, even prescription drugs, because the cost of simply adding coverage for these new kinds of medical treatments, these new innovations, would add significantly to the cost of coverage in the existing system. You heard about Medicaid from Andrew's introduction. I'm sure Mr. Rockefeller, if he were alive today, would be glad to know that New York is still #1 by far in per capita or per beneficiary spending on the Medicaid program. And yet Medicaid programs around the country, state programs around the country, are facing real problems of access to care even within Medicaid because the payment rates have been set so low in an effort to try to control costs in the short run that many providers don't even participate, and many beneficiaries have real problems with access to care. And in some ways, the problems aren't any better on the private health insurance side. What many of the private health plans do is sort of follow the lead of Medicare and Medicaid and try in their own way to negotiate lower payment rates with providers, to take steps to try to get prices down or to restrict access to services like the whole era of managed care, really managed costs in the 1990s. So these are a lot of steps, a lot of efforts, increasingly intense efforts with all the anger and public concern about these issues to try to get some short-term cost savings in health care, but they're really not getting at the underlying problem. These steps to bring down the prices or to restrict access don't do anything directly to improve quality and may actually reduce it. Lowering prices across the board or imposing some broad restrictions on access to certain kinds of treatments in what should be an increasingly personalized and prevention-oriented healthcare system, well, that doesn't do much about the fundamental problems in the way that we're delivering healthcare in this country. Another way of seeing this problem, and another way of seeing why we need a broader approach to thinking about how to get to universal health care, is to remember that spending on health care is prices, what we're paying for services, times the quantities of those services, prices times quantities. And our biggest problem, I'd submit to you, is not that our prices are too high, though there's certainly some more work that we could do on many of those prices. It's getting the right treatments. It's getting the right quantities to the people who need them. And let me give you some examples of this, and I want to start with the path-breaking work done right here at Dartmouth. Since the 1970s, Dartmouth researchers, led by Jack Winberg and more recently people like Elliot Fisher and John Skinner, have done studies showing big variations from area to area around the country in the use of healthcare services and the cost of those healthcare services with no clear relation to outcomes for patients. Costs may vary in Medicare from area to area by 50 or 100% or more, and by hospital treating similar problems by 50 to 100% or more with no clear relationship to health outcomes. That's overuse of medical treatments. Not only that, we have a tremendous amount of underuse of effective medical care in this country as well. This particularly includes our country's poor record of treating chronic diseases. Chronic diseases in this country, diseases like heart disease, heart failure, chronic lung disease, and diabetes account for 75% of all healthcare costs in the United States. You know what our track record is of treating them? It's not very good. Studies by the RAND Corporation and others have shown that the treatments that we know work, where we have clear evidence of benefits from using drugs or other types of treatments to manage these chronic diseases, are only applied effectively about 50% of the time. Long-term compliance with many drugs that can treat conditions like high blood pressure or high cholesterol for seniors, even with drug coverage, run only around 20 or 30%. So underuse of medical technologies. And this particularly goes for prevention. One of the big trends in this country, as you all know, has been a trend towards increasing obesity over time. The obesity rate in the United States has gone from about 17% in 1990 to about 33%, 1 in 3 Americans today. The average difference in healthcare costs per person for someone with and without diabetes is 20 to 25%. What's actually impressive is that over that time we're living longer. Our overall life expectancy and functional impairment measures have been getting better. It's just a very expensive way to go about doing it rather than preventing the health problems in the first place. So underuse of many types of medical treatments and other approaches, innovative ways of staying healthier that could keep our healthcare costs down. And I'm sure many of you are familiar with the problems of misuse of medical technologies in our country as well. A new report was out today suggesting that in the Boston area, 1 in 10 patients who are hospitalized may have important medical errors occur during their stay. And this is after years of attention to the problems of medical errors. Focusing on short-term cost reductions alone hasn't worked to address these huge gaps between what we could achieve in terms of quality and efficiency in healthcare and better health and what we are actually achieving. And this is not surprising. If the focus is just on controlling prices or short-term cost cutting, well, that doesn't work in any industry. For those of you who are economists here, that doesn't work in any industry to get much better quality or value. And these kinds of blunt instrument approaches are increasingly bad fits in a rapidly changing, personalized industry with a lot of innovation. One where there are an increasing array of complex treatments that may be very valuable to some patients, but not valuable at all to others. And the challenge is getting the right treatment to the right patient, getting the right quantities as we keep innovating in healthcare. So what's the alternative? Well, that's what I want to spend the rest of my time on. It's policy reforms that promote real reforms in healthcare. Not just trying to pay a bit less for the same services that we've been getting, but instead putting the focus on increasing value, helping us get more for the money we spend by getting the treatments right. Looking ahead based on what we are spending today and the spending projections going out of increasing spending in Medicare, Medicaid, and private health insurance and increasing out-of-pocket spending, I think this is the only way to get affordable health care to everyone. And it's not just me saying this these days. If you listen carefully to the presidential candidates, every single one of them is saying it as well. This backdrop of rising unsustainable costs due in large part to big gaps between what our healthcare system could do and what it is doing is changing the way that presidential candidates are talking about healthcare reform. For those of you who have been paying attention to elections for a while, you know that traditionally what you're going to see from a presidential candidate is a proposal to cover the uninsured and bring down costs for people who have insurance. Republicans would typically propose something like tax credits. That's what President Bush did in 2000 and 2004. He proposed a $20 billion, $25 billion a year program for new assistance with costs for people who couldn't get good coverage through their job. And then the Democrats would propose something bigger, a broader, more expansive proposal that would get more people covered. But there's no longer much money available to do this. And again, if you listen carefully to the candidates, this is what they're telling you. On the Democratic side, Senator Obama and Senator Clinton both have proposals that they believe will get to universal health insurance coverage. And if you look closely at that proposal, though, one of the main sources of funding for it is what? It's to roll back the tax cuts that were implemented in 2001 and 2003 for the very wealthy, right? Well, if you listen to the campaigns themselves about what they think their proposal would cost in something like our current healthcare system, the number they tend to come up with is something like $100 billion a year. Do you know how much money you get from rolling back the tax cuts for the wealthy? It's about $40, $50 billion a year, right, Andrew? You probably know these numbers better than I do. Let's say $50 billion a year, but keep in mind several other things. First, those tax cuts are scheduled to expire anyway under current law in 2010. So from the standpoint of the quote-unquote official scoring of health insurance reform proposals, that's not new money that you can use for new government spending. It's money that's not in the government's budget baseline. In fact, the big fight in 2009 is going to be between Republicans calling Democrats tax increasers because some of them will want to vote against extending all of the Bush tax cuts. In addition, even if there is some new revenue available from tax reforms, like imposing new taxes on the wealthy or some other steps, there are some very important other priorities in federal tax policy that are going to be, I'll tell you, are going to be addressed first. Some of you have probably heard of the alternative minimum tax and how it's reaching many, many more households than it used to. Fixing the alternative minimum tax problem itself costs over $50 billion per year. So not enough money there to begin with, and money that probably is going to be spoken for other federal policy priorities. And if you want to know just how tight the budget is, many people don't agree with it, but just look at President Bush's budget that he proposed recently. Not only is there no new money in there for health care, there are real cuts in federal non-defense discretionary programs as well, the kind of money that you'd like to find to fund programs like health insurance expansions, just to get to a balanced budget in 2012, and that budget doesn't even include all of the war costs for Iraq and Afghanistan. Money is going to be very tight. Also new this year, now looking at the Republican side, is that there is no proposal for new net spending on health care, and that's something new for Republicans too. Again, last couple of elections, Bush had a significant expansion proposal. If you listen to Senator McCain or any other Republican that was running before, none of them were proposing new spending expansions. They were proposing steps like reforming the tax treatment of health insurance to try to get the federal dollars that are being spent through tax expenditures or other means to go further to cover more people, but they weren't supporting an expansion of federal spending. And that's understandable from a Republican standpoint, because the federal government, if you add it all up between Medicare and Medicaid and the tax expenditures on health insurance for people with employer-provided coverage, that's more than $1 trillion per year in federal spending now, and growing very rapidly. In fact, according to most budget projections, the increases in spending for Medicare, Medicaid, and the tax expenditures for health insurance account for most of the increases in federal government spending overall over the next 5 and 10 years and beyond. So there will be an opportunity. I think the good news in all of this is that there will be an opportunity if and when we get nominees for both parties. I thought it was going to be over by now, but if and when we get nominees from both of the parties to have a health care reform debate that for the first time is really going to be about reforming health care, not just about buying more people into our current health insurance system because we can't afford to do it, but about reforming the way that health care is provided. And it's time for this change in how we think and talk about coverage reforms, because there is growing evidence, practical evidence, that we can take steps to spend the money much better in health care. Not only are there all those gaps in overuse and underuse and misuse of medical treatments that I talked about before, but there are programs around the country, healthcare providers and patients working together who are doing it right, who are doing better, who are putting more emphasis on preventive care and wellness and heading off costly complications before they happen. More emphasis on coordinating care for people with chronic diseases who typically see multiple specialists and may be on multiple kinds of medications or getting multiple different medical treatments that in the past have not been well coordinated. New steps to help patients navigate our whole complex healthcare system, to have patient-centered healthcare that's focused on the needs of a patient, not the needs of all the providers that are treating them. These kinds of steps are what I mean by real healthcare reform. This is what our healthcare system should be driven every day to achieve and should be supported in achieving. But as those of you who are involved in healthcare know, I know there are a lot of medical professionals here tonight, and also those of you who have encountered our healthcare system know, progress towards much more efficient ways of delivering healthcare in this country has been anything but rapid. And this is where healthcare policies and policy reform, I think, really comes in. In contrast to most other industries, if you take steps in healthcare to improve quality and lower costs, steps that create more value for Americans, these steps don't pay off, because our healthcare policies are generally not focused on supporting the best care at the lowest cost. They're focused on something else, and usually it's more volume and more intensity of services, regardless of their quality or their impact on patient health. And in that kind of a financing environment, in that kind of a regulatory environment, the real reforms in healthcare that we need don't come very easily. I had an example of this soon after I went into government in this administration, was still working over at the White House, and I heard from a group of surgeons, thoracic surgeons, who had what sounded to me like, when I talked to them, a very good idea. What they wanted to do was coordinate the care that they were providing for bypass surgery and other elective heart surgeries in a new way. They wanted to have teams of doctors, of surgeons working with nurses and anesthesiologists together that would have standard operating procedures. They wanted to use electronic records to do handoffs to the post-acute care team. After you get discharged from the hospital, there's a lot of recovery time after major surgery, like heart surgery, to get you back on your feet, and a lot of things can go wrong in that recovery time as well. They wanted to implement steps that they had shown could reduce infections and so forth, and they had piloted these programs in a few hospitals, mainly in Virginia. And what they had found was that when they took all of these steps, several things happened. One, patients got better outcomes. They had lower complication rates, shorter length of stay. They had better functional outcomes as well. Two, cost of the Medicare program went down. The problem was that they had to make some investments in things like coordinating the care teams and investing in electronic medical records and communicating effectively with the post-acute care providers that cost money. But under the Medicare reimbursement system, where you get paid more when you have more hospitalizations and more imaging and longer rehab stays, they lost money when the hospital and the physicians lost money when they took these kinds of steps. They had what seemed like a pretty simple idea. They wanted to get paid in a different way, where if they documented that they were actually improving quality and lowering overall cost of Medicare, all they wanted to do was share in some of those savings. Well, it seemed like a nice idea to me. Unfortunately, when I talked to the lawyers, they told me it was illegal. The way that Medicare pays is based on volume and intensity. In fact, there are specific rules, the Stark and anti-kickback regulations, that prohibit any kinds of sharing of funds like that between the hospitals and the doctors, the other kinds of providers involved. Well, that's an indication that something needed to change. And over the last few years, there has been some very important progress towards getting to a healthcare financing system and getting to healthcare policy reforms that really support value, that really support steps like what those thoracic surgeons wanted to do to get to better care at a lower cost. And there's several key steps in doing this that I want to spend a little bit of time on. The first is measuring what we really want, not how many services a patient received, not how long, not simply how long they stayed in the hospital or how many costly complications they had, but what their results were, measuring quality and measuring the efficiency of care. A lot of work going on here and elsewhere around the country to develop measures of quality of care, including measures of evidence-based processes of care, best practices, but more importantly, measures of the outcomes that patients experience, whether they have important complications, whether their chronic diseases are actually under good control so that they can stay well. And very importantly, patient satisfaction measures as well. There are public and private efforts underway now. In fact, at the Brookings Institution, we're coordinating an effort across a number of quality alliances for hospitals, for ambulatory care, for pharmacies, to try to do a better job of measuring the quality and the cost of care. It's very important to keep the focus on the patient in these activities, not just hospital care or physician care, not just particular processes of care, but the overall results that the patients receive. Not only do we need to measure results better, quality and cost of care, but we also need to then take steps to change our payment systems, change our regulatory systems to support these kinds of reforms. And this is starting to happen as well. Medicare now has what's called pay-for-reporting for hospitals and for some physician measures of quality. These are just some initial steps, but they're steps that we can build on. There are pilot programs underway now in government and in the private sector through business collaboratives like the Leapfrog Group to start paying more for better results on quality, not just paying for reporting on these kinds of quality and cost measures that I mentioned, but if healthcare providers, if physicians or a hospital do better on some of these process of care measures, they get a little bit of an additional payment. It's called pay for performance, and it's a step in the direction of providing better support for value in healthcare. The problem with many of these pay for performance efforts that are underway now is that they amount to just incremental changes on top of a fundamentally misdirected system for supporting true quality and efficiency in healthcare. And so when you make these incremental changes, you tend to see incremental effects. Pay a little bit more for doctors to do a better job of keeping patients on the right prescriptions for their chronic diseases, and you'll see a measured improvement in the use of those chronic disease medications, but it comes at an additional cost because you had to pay more for the payment incentives. It's not a fundamental change in the kinds of incentives and support that providers receive for delivering quality of care. But it is possible to go further than that, and that is through steps like what I was talking about earlier with what the thoracic surgeons wanted a few years ago. It's the idea of shared savings, and it's not that far off. Under this kind of payment system, instead of paying more simply for more services and more intensity of care, and then maybe tweaking a little bit on the margin for quality measures, for a limited number of quality measures, this kind of system offers a different deal to providers. And the idea is the providers can document that they're getting better overall results for their patients at a lower overall cost than they can share in most of the savings provided. Again, Dartmouth is leading the way in these efforts. Medicare, while I was CMS administrator, started a demonstration program at 10 multi-specialty group practices around the country, including the Dartmouth Hitchcock Clinic right here at Dartmouth, to provide this kind of system. And under this approach, Dartmouth Hitchcock and the other participating groups report on how their patient population that their multi-specialty group practice treats is doing in terms of a range of preventive care measures, like using flu vaccines effectively for patients where it's indicated, using preventive tests for cancer effectively, and also measures of quality of care for the 6 or 7 chronic diseases that account for most Medicare costs. It's not that complicated. These are conditions like heart failure and diabetes and chronic lung disease that account for most Medicare expenditures. And the group's reporting not only on those so-called process of care measures, but also on outcomes for the patients with these chronic conditions, and also on some standardized patient satisfaction measures. And if they document improvements in most of these measures of quality, Medicare is also tracking the overall cost that Medicare is paying for their care. And if they document improvements and reductions in the overall cost trend in Medicare, they get to keep a significant part of the savings above a threshold. So I hope you can see that this changes the way that support for efforts like those thoracic surgeons that I mentioned earlier, changes the way that support for their efforts works. Now, under this kind of system, if you take steps like investing in an electronic record system so that you don't have to order so many lab tests and that you don't have to see your patients so often, and maybe you can keep them out of the hospital or even out of your office, or if you invest or if you hire a nurse practitioner to help your most challenging patients with chronic diseases stay well and head off complications, well, now it actually makes financial sense in Medicare. Under the old system, all that would happen is that you would have fewer visits, you would have fewer lab tests, Medicare would pay you less, and it would be harder to make ends meet in your practice. Now it makes financial sense because you can share in the savings from those kinds of reforms. So my hope is that by building on these kinds of efforts and payment reform and Medicare, and also some private sector payers are doing this as well, we can provide a much better support for the kinds of healthcare reforms that we really need. We also need to take steps to develop more evidence on what works to help drive better care decisions by healthcare providers. As many of you know, since Dartmouth has led the way in these kinds of studies as well, more than half of all medical practices, according to many estimates, are not evidence-based, particularly those practices that account for the big variations in the use of medical services that researchers right here at Dartmouth have identified. Unfortunately, it's hard to study these kinds of variations in practice in traditional randomized controlled trials. Typically, the reason that practices and utilization varies from area to area is not because of any one specific intensive procedure or any one specific brand name versus generic drug. It's because of different styles of practice. For people with chronic diseases, there are big differences around the country in how often physicians see those patients themselves, how often they refer them to specialists, how often they do a range of supporting laboratory tests and imaging procedures, how often minor surgical procedures are performed. It's not any one particular treatment decision. It's a pattern of care. And we haven't done a very good job of generating good evidence on the impact of these differences in patterns of care, and especially on the impact of different kinds of healthcare policies in influencing care in a way that may lead to better results at a lower overall cost. There is new momentum coming for generating better evidence on what works, though, from a variety of sources. Last year, major reform legislation for the FDA was enacted by Congress and signed by the President. This legislation envisioned creating a new active surveillance system in this country for drug safety, so that by using data from electronic record systems on prescriptions that are filled and complications that patients have, we would have a much more automatic way than we've seen in the past of learning about adverse events that in the past have taken many years to find out about, because we haven't had this kind of system in place. There also is more support for developing evidence on what's working in actual healthcare delivery through policies like coverage with evidence development in Medicare and in private healthcare plans. So more evidence to support these good practice decisions and these financing reforms is coming along as well. A final powerful factor that I want to mention is changes in the way that health insurance benefits work. These are changes that are focused not just on providers and giving them the support they need to implement effective reforms in medical practice, but reforms that can enable patients to save money when they take steps to get the care that they need at a lower cost. And one of the things that I got to do while I was in government was implement the new Medicare Part D regulation. That came out, that new benefit came in while I was at CMS. And one nice thing about starting a program like that, I came to CMS just after the law was passed, was that you always want to start a job with low expectations, right? So if you'll remember, back then when the benefit was enacted, the expectation was that it wasn't going to work, that prescription drug-only insurance couldn't work, that the costs were going to be much higher than people had projected, and that no one was actually going to sign up because it was too confusing. Now, this was a challenging program to implement, and it was one that, compared to just having the government define one benefit and give it to all seniors, would have been much easier for seniors to participate in. On the other hand, we had three main goals when we were implementing the program. One was to bring it in, one was to make sure that people could find out about it so that if they wanted to sign up, they could. And at this point, there is enrollment of more than 90% of people with Medicare in prescription drug coverage. A second is to have a benefit that would work for most people. And the satisfaction rates, I know it's been frustrating for many people, but the satisfaction rates with the coverage have been quite high. They're up close to 90% of people who are fully or partly satisfied with the coverage. And we also wanted to bring it in at lower than expected costs. And the costs right now in the program are running about 40% below the initial budget projections for what this program was going to cost before it was implemented in 2006. A very important reason for that is that almost no one is in the standard drug benefit that was in that law that was designed by Congress. The standard drug benefit was, had a deductible, then 25% coinsurance, then catastrophic coverage on the back end. And between that, there was the famous donut hole. You guys remember that, if familiar with the program? By the way, if the people had now the budget estimates, the cost estimates, had been the cost estimates that we have now, there wouldn't be much, if any, of a donut hole because the costs have turned out to be so much lower than expected. But the Congressional Budget Office doesn't let you go back and adjust like that. Usually the healthcare cost estimates go in the other direction. They turn out to be a lot higher than what had been projected. There are a number of reasons why costs have turned out to be much lower than expected, but one very important reason was that people chose a different benefit design than what Congress had envisioned. Almost no one is in that standard benefit that I just described. What people have overwhelmingly chosen is what's called a tiered benefit, where if you use a generic drug for treating your health problem, it may cost you $1 or $2. Some plans have them available for free. You pay almost nothing. If you use one of the so-called preferred brand name drugs, where the plan has negotiated a lower price on the medication in the class, and there are about 11 classes of medicines that account for most prescription drug spending among seniors, most outpatient prescription drug spending among seniors. Well, that preferred brand name drug will cost you a flat $20 or $25 a month, and most other drugs are covered, but people pay a significantly larger part of the cost for them. They're on a higher tier in the plan. And what happened in the implementation of the benefit was two things. One is that people overwhelmingly chose this benefit design that had lower premiums and lower cost per person. And then two, people switched drugs. The use rate of generic drugs among seniors in this country is now, in Part D, is up to about 65%, almost 2 out of 3 of all prescriptions. That's much higher than it was in 2005. Then, and in Medicaid today, generic drug use rates are only running about 50-55%. Now, there's been a lot of discussion about getting the prices down for Medicare Part D drugs, and there probably is, there may be some more steps that we can take, and we should keep looking closely about whether there are good ways to do that further. But when you switch from a brand name to a generic drug, you don't save 5 or 10% more in additional discount. You save 70 to 80% off the cost of the medicines. When you switch from a non-preferred to a preferred brand name drug, savings are typically 20 or 30% or more. So by switching the drugs, the cost of the program turned out to be much lower than expected. And this was driven by patients. This was driven by patients getting personalized information about how they could save money by switching medicines and by having the opportunity to actually save because they were in benefits that enabled them to capture those savings themselves. They weren't savings that went somewhere else in the system. They went right back to patients. So there are some very important steps as well in implementing this kind of choice-based system. I need to pay a lot of attention to making sure that people who are at higher risk have access to adequate coverage, and we try to do that through steps like risk adjustment and other types of government oversight. You need to pay a lot of attention to making sure good information gets out, and there certainly is more that can be done to help people be informed consumers about their health care and help make this easier for them. But patients, consumers, are an extremely powerful force in getting the quantities right and finding better ways to help people meet their medical needs, their increasingly personalized medical needs, at a much lower cost. So all of this is to come back to this question of where I started, on getting affordable coverage for all. We need to build on steps like the ones I've just talked about to get more value, to measure quality and cost, to promote payment reforms and benefit reforms and other policies that support better healthcare quality and lower overall costs. And this can fit into the debates that we're having about coverage as well. They shouldn't be separate. They should be combined. This past year, there was a big battle over children's health insurance in Washington, right? You all followed the S-chip debate, and for most people who are following this, where that ended up didn't give people a lot of optimism that we're on a path towards broad consensus about health insurance coverage reform. But I think that was in part a reflection of how the debate was cast in Congress this past year. There were two alternatives presented. One was basically an expansion of the kinds of programs, the Medicaid and S-chip programs, that have worked very well for families and children with incomes under 200% of poverty. The other was basically not expanding those programs at all. Now, I want to contrast that with what's happening in state capital after state capital around the country, where Democrats and Republicans have gotten together, if not to enact coverage reforms, at least to take steps towards doing so. Massachusetts did it. California came close. Other states that have not gotten as much press because they weren't going to universal health insurance coverage, but were still doing significant coverage expansions over the last couple of years, like Arkansas and Montana and many others, did this as well. What they did was something in between those two alternatives that I just outlined. They didn't just say that the government government programs are only for people with incomes of under 200% of poverty, only for the poor and nobody else. They said that, look, at higher income levels, people need some help with affording health insurance today. Maybe they don't need 90% or 95% of their health care costs paid, like is the case for people with incomes under 200% of poverty, but they need some real help. 40%, 50% subsidies up to 300% of poverty or so. That's what happened in Massachusetts. That's how they got a compromise there. People have a choice of health plans, but they get help. They get help on a sliding scale. Employers contribute something. Individuals contribute something more than they do at low income levels, and the government helps as well. That's a more sustainable model, at least many of these states that were enacting bipartisan reforms found. It's a more sustainable model than either of those two alternatives that were discussed primarily in Washington. And if you combine those kinds of steps with steps to get patients involved and steps to reform payment systems, as I've just described, well, then you're on a path to getting more affordable coverage for everyone. How can you do this with money as tight as I was just describing it earlier this evening, with the budget being as tight as it is in 2009? Well, one place to go is something that both Republicans and Democrats have now put on the table for health insurance reform, and that's for changing the way that our government health insurance for subsidy for private employer-provided coverage works. For those of you who have been following this, you know that health insurance, if you get it through your job, is entirely tax excluded. It doesn't count for your income at all. That is actually by far the largest tax expenditure in the federal tax code. A lot of people think the biggest tax expenditure is for the home mortgage deduction. That's something that most people take advantage of, and that's a big deduction. It's worth about $70 billion per year. You know how much we spend on the health insurance tax exclusion? If you count federal taxes and Social Security and Medicare tax exclusions, it's about $240 billion. And you know how regressive it is? More money from this exclusion goes to families with incomes over $100,000 than goes to the much larger number of families with incomes under $50,000. So it is not surprising in this era of very tight fiscal concerns and very big concerns about rising health care costs that Republicans and even some Democrats have put on the table reforming this health insurance exclusion, not taking it away from people with employer coverage, but maybe putting a limit on it and using some of the savings to make health care more affordable for people with lower incomes. Combine that with the kinds of reforms that I was just talking about at the state level that have already gotten bipartisan support, and the steps towards paying more for better care and involving patients more in their care through choices that let people save money when they meet their medical needs at a lower cost, and you're well on your way to providing universal coverage and universal health care access that really is to quality, affordable care. Now, none of this is going to be easy, and efforts to find common ground, like the ones that I've talked about, to refocus on value and more targeted, efficient care, are going to be challenging. But I'm optimistic because there is too much at stake. There are too many opportunities coming along for more personalized, more integrated, high-quality health care that can help people live even longer and better lives than we're experiencing today. So I think the fundamentals are good for healthcare delivery system reforms, for real healthcare reforms that move towards patient-centered care, towards this focus on getting much more value, especially if we can help hasten these efforts along through the kinds of healthcare policy reforms that I've just described. I think the time is now to have a new kind of public dialogue about real healthcare reform. We're primed to do it in this presidential election, and we're primed to act on it in 2009. Let's make it happen. Thank you all very much for the opportunity to be with you tonight. Thank you. Thank you. And we've got some time. Yeah, can take questions. I don't know if there's a roving microphone, so I'm going to start over here.
You did mention the idea of prevention. And it seems to me where the prevention can really be started is getting all children having health care. And it's not
health
that
insurance,
good.
You mean?
Yeah, the CHIP program which you mentioned.
Right.
And it's been cut. That budget has been cut in the federal budget that just came out. There's not enough emphasis on that stage. If you get the kids started early, you're not going to have some of those other things happening later. So I really think that that's where one of the major things has to become. The other place where medical costs are so high is that 30% in the cost of figuring out insurance forms, the hospitals and the physicians spend 30% of their time doing that. And by having multiple health insurance programs don't seem to do the job. Their profit's the main thing that they're worried about.
Well, let me comment on that point about administrative costs. I'm not sure they're quite 30% of the costs in our healthcare system, but they're a lot, and they're a lot higher than they could be. And I think there are some real benefits to having choices of insurance plans around. If we didn't have choices of insurance plans, we wouldn't have gotten to a lot of the steps that have now been proven to work for better coordinated care for people with chronic diseases and for new kinds of wellness programs. Those kinds of programs were not started in the traditional Medicare program or traditional Medicaid programs, which were much more of the fee-for-service variety that I was talking about earlier in my remarks. But there is, I think, a lot more that we can do to prevent all of the additional administrative costs from non-standardized forms and the like. There have been some federal efforts underway to try to get to standardized ways of sharing information about patients, basic information on care. And the other big place where a lot of these costs comes in are related to underwriting costs, where plans are competing not by offering better care at a lower cost for people who are healthy and for people with chronic diseases, but by trying to offer plans that focus just on the healthier people and trying to avoid those with pre-existing conditions. A lot of the reforms that have been talked about and some that have been implemented already in places like Medicare and Medicare Part D prohibit any kind of underwriting based on pre-existing conditions. You can't just prohibit it, though, because that creates some other problems in health insurance markets. People who have high cost, or people tend to wait until they have higher costs to get insurance. But there are other steps that can be taken to address it, like paying plans more if they are able to attract and keep happy people who have chronic diseases, who have the most to gain from those kinds of coordinated care steps. So there are some reforms that could be implemented to get, I think, those administrative costs way down. And I totally agree with you. That's got to be a big part of our solution to the healthcare coverage problems in this country. See, I'm sure where you want to go next. Who's we down here in front?
I can speak
Okay. I think they want your voice for posterity, though.
So you've talked about, you started off talking about some of the problems with the American healthcare system, and I'm sure, there are lots of statistics for this, how our population outcomes like infant mortality are really slipping compared to Western European countries. And you've talked about a lot of promising programs to change funding with group practices that can really both improve access and reduce costs. But you also mentioned that the Dartmouth research showing the fragmentation of the American healthcare system. At what point should we still be talking about reform, and at what point should we be talking about how our system is, where do we draw the line when our system's no longer working and it's not anymore a question of reforming things, but a question of creating a new healthcare system?
Well, I think that, I don't know that you need to draw the line. I think the question is how can we get better results for our population as effectively as possible? And I think those go into, your question actually opens up a whole new area. One area is making our healthcare systems work better. And as I try to talk about tonight, we're getting what we pay for. If we pay more for more complications, if we pay more in these areas where Dartmouth has found costs to be higher. And then, the Dartmouth research, they're great. They've been documenting this for 30 years now, and it just keeps getting bigger. And if we keep paying more for that, then of course that's what we're going to get. In contrast, if we pay more for better care at a lower cost, better results at a lower cost, I think there's growing evidence that that's what we'll get as well. But a lot of the kind of statistics that you're talking about, like infant mortality and overall population mortality rates for that matter, really are driven by things that go way beyond healthcare. And it's not healthcare differences that account for that. I think according to one of the studies published in JAMA last year, some of the wealthiest groups of Americans who don't seem to have much trouble with access to healthcare at all have worse health outcomes than middle class or even lower middle class people in other countries. And this is driven by other things. And while it's been hard to get a handle on, things like education and personal preferences about risk and other types of personal behaviors, environmental factors, things that go way beyond our healthcare system are primarily responsible. The Robert Wood Johnson Foundation is about to launch a new commission week after next, which I'm a part of, that is going to try to put a much bigger spotlight on these non-healthcare factors that seem to be playing a big role in the worst overall health outcomes in this country, and particularly the worst health outcomes for groups with lower socioeconomic status in the United States. These things are driven by factors that I think go way beyond health care. And one additional advantage of putting much more of a focus on getting to better health outcomes in our healthcare system, as I was talking about tonight, is I think it would make it easier for bringing in policy initiatives from other areas, from public health, from education, from environmental policies, from transportation policies, and so forth, that probably, if you think about it, are going to have more bang for the buck in terms of federal spending on health outcomes than some healthcare initiatives might. Yeah. If you all want to just go, like, anybody's fine. It's, who's the lucky next person? And if you want to just go to a next questioner, so we can go right to them after this one's done. So go right ahead.
Yeah, one of the I'd like to talk about the idea of universal healthcare for a while, socialized healthcare.
Universal health insurance?
Yeah, universal health.
It's not the same thing as universal healthcare. I hope I was clear about that.
Right. Sorry. One of the main arguments that opponents of universal health, socialized health care I'm talking about now. I'm talking about similar to the systems they have in France and in England. One of the main arguments that opponents present is that if you socialize health care, something that'll disappear is the competitive technological edge that America holds in the international community. Exactly. Innovation will decrease. And that makes a lot of sense. You have the capitalist system now competing, and they're developing new technologies in order to increase business. So I'm wondering if you could speak to that, if that claim is well founded, if there will be other balancing factors that will develop if healthcare is socialized. And my second quick question is, what did you think of Michael Moore's movie Sicko?
So quite a movie. I think some people thought he went over, kind of over the line in suggesting that the Cuban healthcare system might be better than ours. But he certainly pointed out a lot of cases where, for people with sort of the run-of-the-mill health problems that account for most healthcare spending and account for most of the burden of disease and disability, care is more straightforward in many of those other country systems, and that's sort of a very attractive feature of systems with central planning and budgets that are awarded. And by the way, these countries are quite different. You know, France is not the same as England. There's different financing mechanisms, different role for individual choice, and the like. What I find interesting, though, is that if you go abroad, the general trend there is kind of reverse of the trend here. Here, over the past couple of decades, we've seen a steady increase in the federal and government spending as a proportion of total healthcare spending. And while there's still a lot of patient choice in the system, there's certainly getting to be a much bigger role for government than there was, say, 20 or 30 years ago. The trend is upward. In most other countries that you were talking about, like France and England, the trend is the reverse. Actually, the extent of private choice is increasing. In Britain, there's now a much larger, it's not even a fringe anymore, but a much larger private hospital system and even private healthcare delivery system. There now are plans that people can buy that give them, through their employer, that give them access to all the drugs that the National Health Service doesn't cover for certain indications and the like, and that's actually growing. The Netherlands, Germany, many other countries are now moving towards more patient choice in deciding how healthcare dollars are spent, and even more private spending on top of the public spending before. And what that suggests to me is that there's clearly a role for both government involvement to help make sure that we're competing and people are making choices based on the right kinds of things, but also a role for private choice and involvement. And the reason that most of these other countries are doing it is not because they feel a compelling need to become more competitive. It's because their systems were having gaps. They're not having gaps in the same places that ours is, but they were having gaps in access to some innovative treatments and reforms in the way that care is delivered to put a greater emphasis on care coordination for chronic diseases like I was talking about before. So I think that, you know, if you look 20 or 30 years down the road, there's probably going to be a good deal more convergence across international healthcare systems than we see today, and certainly a role both for choice and rewards for innovation, like you can get in a system that doesn't have just strict government budgeting, but also a role for the government to help promote competition that's on the right kinds of factors to help make sure that people, especially those with limited means and high healthcare needs, have access to good coverage, and hopefully we can find ways to get it right. I don't think it's an either-or solution down the road. Yeah.
This is along the same lines about single payer and also, I know you've been speaking to this, but why you don't think a single payer nonprofit system in each state would not work. Wouldn't they be more likely to adopt the kinds of programs that you were speaking about in the beginning, the standard procedures and all kinds of things like that, if it was just one payer that you're talking about, instead of trying to convince how many insurance companies to adopt those programs? Look how long it took the private insurance companies to adopt any preventive care at all. Well, I mean, they seem to work in the opposite direction of what you're thinking. And do you really think that healthcare in this country should be a commodity and a profit-making business? I mean, that's what it is. And the people who can afford it get the best care, and those who can't, the people who don't have business-covered employment, and we have a lot of small businesses in this country and self-employed people who don't have business-sponsored, employer-sponsored health insurance, they don't benefit from that $240 billion that you're talking about. They have to pay
they get no help.
out-of-pocket after-tax dollars for their private insurance. It's not fair. It is
really
not
unfair.
equitable. And I think some of the things that you're saying aren't bringing us towards a more equitable system. Isn't that important?
Well, I think, let me talk about this point about equity and then maybe get to the bigger philosophical issues. If I wasn't clear, let me be clear. I think our healthcare financing system today is very inequitable. If you think about where the subsidy are going, that $1 trillion plus that the federal government is already spending on healthcare, It is not, if you just grab someone on the street, maybe you, I don't know if you'll agree with this or not, but when I talk to students or other colleagues, the first thing that, and these are people who don't specialize in healthcare, don't think about it every day. The first thing is, what should the federal government be concentrating its money and its efforts on? It's first and foremost on people with limited means who have the most trouble getting access to care and affording it on their own, and people with chronic diseases, people with high healthcare needs who are going to face very high costs if they don't get help. That is not where the federal subsidies are concentrated in our system today. As I talked about earlier, particularly the tax subsidy, but not only that, the Medicare subsidies as well, as John Skinner, who's in the audience, knows, tends to go to people who are higher income, who live longer, and who have access, even within a government-run health insurance program, to more intensive, costly approaches to treating some of the conditions that they have. So absolutely, I agree with you that we should be reforming the way that the federal government subsidizes health care to first and foremost concentrate our limited resources on the people who need it the most. Now, there are these big philosophical questions about whether we should be doing that in the context of a single-payer, government-run system, or a competitive system. And maybe I've been in Washington too long, but the focus there, I have to tell you, is that no one in Congress expects to bring up to a vote in the next year, the next 5 years, the next 10 years, a single-payer system or a single or across-the-board competitive system. Yes, there are those proposals out there on both extremes, but nobody expects that that's going to be what happens anytime soon. Where a lot of the attention is focused is on more incremental steps that could lead to more fundamental improvements in the way that healthcare is delivered, starting with the people like you were talking about in small, who are working for small employers that aren't lucky enough to get health insurance on the job and who are getting absolutely no help in either subsidies for their coverage or in access to a low-cost system for choosing their coverage. And so that's where a lot of the efforts are being concentrated right now to try to improve access to care. And with respect to the question of philosophically which of these approaches is better, well, besides the fact that we're not likely to get to an opportunity to test out one extreme or the other in the next few years, I think the evidence is kind of suggests to me that both have their drawbacks and both have opportunities to do a much better job than we're doing today of making affordable coverage available. You mentioned that some private health plans haven't done a good job of providing access to innovative benefits. Well, certainly the same thing could be said for the largest government-run healthcare program in the world, which is Medicare. Medicare didn't cover drugs until a few years ago. It's still behind on preventive services. It doesn't cover any kinds of electronic health care. It doesn't, as a general matter, cover care coordination services for chronic diseases. And these are all steps that we know, done right, can lead to better outcomes and lower costs. In all of those areas, it's actually the private health insurance plans that have been ahead, in part because people can choose to go to a plan that offers these kinds of benefits if the plan that they're in now doesn't have it. You don't, until recently, people in Medicare didn't have that kind of choice. On the flip side, it's absolutely true that there are things that you can do through large programs, large government-supported programs like Medicare that are harder to do in any single private insurance plan. Some of the steps that I talked about, like paying those thoracic surgeons better, were easier, couldn't have been done just by the private sector by itself. Too much of the care that those surgeons are providing is paid for by Medicare. So if any individual private plan wanted to do it, even if they wanted to, they couldn't have enough of an impact on care delivery by themselves to change things. So it suggests to me that both of these systems have something to offer, and that there are steps that we can take to make both private insurance and public insurance work better. And maybe over the next few years, it'll become clear that one system works better than the other. I think it's unlikely that we're going to see that kind of fundamental reform in this country, but I absolutely think there are a lot of things that we can do now to make both private insurance and public insurance work much better. And I think there's some bipartisan ways to move forward on that I hope we'll do real soon, starting hopefully next year after the election. And next.
Hi. There's this talk about healthcare reform and constraint money, but yet there's no talk about the pharmaceutical companies. They make billions and billions of dollars, but none of that money goes back into the healthcare reform. So is there like a aspect where they're going to try to get that money to go into the healthcare reform and help pay for all these insurance and stuff like that? Because again, the pharmaceutical companies don't put any money back in there, but yet they make so much money.
there are high profit rates among pharmaceutical companies, just like there are among a lot of other kinds of private companies. And one of the challenges that we've had, just kind of building on the talk that I was already given, is that in a healthcare system where we tend to pay more for more intensive services, even if they're not really worth a lot more, it does tend to create incentives for private companies to try to deliver products or deliver services that may not be really focused on adding value for patients as much as being a Me Too drug or something like that. But I think if you really want to solve this problem and get more medical innovation from pharmaceutical companies or others that truly adds value, you need to go back to the kinds of steps that I was talking about today. If health plans and if Medicare didn't pay more for a drug simply because it was new, but instead because it made a bigger difference in the health outcomes for a patient, I think you'd see a different kind of medical innovation than we're seeing now. Medical innovation that would do a much better job of helping people live longer at a lower overall cost, consistent with the goal that I was talking about before. But without any kind of financial support for innovation, I think it is less likely that we're going to see quite as much innovation. And there is a tremendous potential for new kinds of genomic therapies, stem cell therapies, and so forth that if we don't provide financial support for that, we're not going to see as rapid improvements in health as we could. I would just like to see those kinds of reforms supported by a much greater emphasis on treatments that actually make a difference in patient health.
I work in the imaging industry, and we have to do the pay for performance, and I do think it's a little incremental step, but it is going the right way, and evidence-based medicine clearly has to come in. But there are two issues that came to mind when you were speaking, and one of them is there's a zero-sum gain, really, when it comes right now with Medicare and the payments they're going to make, and when people come allowed to invest in MR, CTs, and to get money from that when they send patients to them and go around the Stark laws in a roundabout way, and they're basically making money the more people they refer.
When they own their own.
When they own their own equipment. And so there are abuses out there, and you see this over and over and over again. And I can tell you, I heard the comment that when people said, they're going to decrease the amount of reimbursement, you only can reset those every so often.
Right.
Their salary is not going to go down, so in their mind, they're just going to order more. I mean, it's almost it's a catch-22. It just catches.
But that's exactly what's been happening in recent years with Medicare's physician payment system. Is that physicians are paid based on volume and intensity, and their procedures like these imaging procedures that are sort of high-margin procedures. So when the payment rates get cut across the board, it's not surprising that you see more time and effort on these kinds of high-margin services, and the payments get cut again, and the cycle kind of repeats.
There are multiple issues there. One is, the radiation dose for the patient, number one. Number two is they're siphoning off the patients that usually have the ability to pay, leaving the non-paying patients for the hospitals or others to take care of. And it seems like that would be a temporary thing that they could at least close. I know it's just a Band-Aid situation, or take away the incentive completely, which is what you're referring to with the thoracic surgeons is, get the evidence-based medicine in there and get the results. But in the meantime, they could be shutting the door on some of those abuses. And the other one is you see an awful lot of imaging studies being ordered specifically just to avoid lawsuits. And I don't know how people could just stop that. I mean, those two things right there would, even though they're only temporary, would really change the amount of money that would be going out the door.
Yeah,
while you're trying to implement the other processes.
I think those are all good points. I think that they all go back to, though, the root cause of the problem here is that we're not paying for what we want. We're paying for more imaging procedures at a high margin rather than paying for the better results for patients who are getting the imaging procedures that would help doctors do what they'd like to do, which is, I think, deliver care more efficiently and only do the imaging where it's really going to be helpful. It's just hard to do that under our current financing rules. And I think this more attention to outcomes and doing a better job of confidently saying, okay, this is the best treatment for you, and people like you who are treated this way have better results. That's got to help with the liability pressures too. I mean, right now a lot of the lawsuits are driven by bad outcomes that may or may not be related causally to the treatment that was provided. If we did a better job of connecting the treatments with the results, then it seems like there'd be less pressure on physicians there as well.
Thank you. I just have a quick question. I enjoyed the direction that you took your discussion tonight. It's a fresh discussion to hear. My question is, coming from a family that has a physician in it, what can physicians do to help? Because right now, my mom's looking at just discharging all of her Medicare patients and not seeing them anymore. And that's a painful thing for her to do because they're her favorite patients. Is there something she can do to help the process move forward?
Yeah, I think there absolutely is, and we've got to have a better answer for physicians like dedicated physicians like your mother than just hang in there and we'll get around to this sometime. It's you just can't. We're getting to the point where these physicians can't even make ends meet. One of the things that I've noticed over the last few years is that the organized medicine groups, and I'm not sure if you mind my asking, what specialty is she in? Family practice. So the family practice doctors have been, in the last few years, completely out front on reforms in our payment systems and coverage systems along the lines that I've been talking about. The American Academy of Family Physicians has developed a proposal called the medical home concept, where instead of having internists paid based on all the lab tests and imaging, and getting paid more when they buy a CT scan for their office and start scanning all their patients, give them a payment for coordinating the overall care for the patients that they're primarily responsible for, and then give them additional payments if they're able to achieve improvements in coordination of care, the results for those patients, or getting the overall cost of care for those patients down. And that's very consistent with what I've been talking about tonight. And to their credit, the family practice groups have been out front on urging Congress to consider these kinds of changes every time these Medicare payment issues come up. My hope is that as the pressure mounts for getting away from this current unsustainable, vicious circle system where you lower the payment rates and then you get more volume and then you lower the payment rates again, and the whole time quality's going down, not up. As the pressure goes up there, and as there's more evidence that these kinds of medical home payment systems can really work, that we'll actually be able to get it implemented. And this will be a legislative issue this year. So it's very hard for an individual physician to make a difference, I know, in these overall policy issues. But the family practice groups have been coming together, and I think are getting pretty strong support now from their membership for exactly the kinds of payment reforms that I've been talking about tonight.
I just, this is sort of a follow-up on the previous question. I like what you say about pay for performance, and I'm here at Dartmouth, right? So I agree with the model, paying for higher value care and effective care and not just per volume. But when I hear the discussions of pay for performance, if you just sort of closed your eyes and thought you were 15 years before, you just insert managed care there. And we have very similar discussions. You go back and read the literature, right? We talk about it in the same way. This was going to be, managed competition, and so you would have the providers sort of competing about value and quality rather than about cost or volume. You talked about capitation as just a similar kind of thing. And what I'd like to maybe hear your comments on, might we do a better job now thinking about the potential problems we might see in pay for performance that we didn't see coming, or maybe some people did, with managed care? Because when managed care was done right, it did all of these things. There was high quality care, better delivery, bringing in patients.
Yeah, there's some managed care plans that are doing a demonstrably good job of this today.
Still doing this today, and yet others, of course, started to compete more on cost and excluding people who were high-risk patients and all of that. I mean, do we have risk of that in pay for performance, and what might be the things that we watch for as we try to implement pay for performance?
Absolutely. It's a really good question, and I guess a couple of points, but there are probably many, and this is exactly what we should be doing as we implement any kind of health policy reforms, particularly these that can have potentially such a big effect on the healthcare system. Remember, managed care reforms 50 years ago, or 15 years ago, weren't really about managing care as much as they were about managing costs. And there's a lot of discussion about managed competition, but back then there were hardly any good measures or good awareness of the public of differences in quality among their their health plans. And I'd submit that that's still true for most people today. And if you ask most people what's important to you in a health plan, it's not, this plan is, I chose this plan because it's clearly superior in terms of getting better outcomes for people like me at a lower cost. They say, no, I chose this plan because my doctor's in it. So we still have a long way to go on giving people confidence that they can make a choice about their coverage based on something other than what their most trusted health professional recommends. And a good sign that we have gotten there in terms of valid measures of quality to go along with the emphasis on cost is that people will be more willing to make decisions based on the information they get as opposed to just based on what their doctor may be telling them. We're there in some areas already. I mentioned Part D earlier for a reason. People believe, most people in this country believe that if a generic drug is available for their condition and it costs a lot less, it's okay to switch because it's the same drug. And most people were willing, many people, it turns out in Medicare, are willing to try a preferred brand name drug that costs much less than the one that their doctor initially prescribed because they think it can do just about as good of a job for their health. People aren't there yet when it comes to picking their surgeon or picking their primary care doctor or picking a health plan. So we've still got some more work to do on making these quality measures work. And when that happens, then you'll really have competition around quality and cost. So that's one thing, is these better measures of quality and really driving that forward. Second thing is there's this problem of adverse selection that I mentioned, that a lot of competition in the 1990s and still too much competition today is about on avoiding people with high costs, even though, if you think about the actual facts, it's those people with high costs that have the most to gain from care coordination and from all the kinds of services that a good health plan ought to be able to provide. And that's our fault from the policymaking standpoint. If we set up a system where you can make more money by competing on excluding the chronically ill than you can by providing better care for the chronically ill, and there's tremendous opportunities to do that. I mean, I gave you the statistics. I mean, there's appalling how bad care and coordination for chronic illnesses in this country. There's tremendous opportunities to do much better than we're doing today. And there ought to be a way to focus competition to make that happen better. In Medicare, a big step over the last few years has been what's called risk adjustment of payment systems. So now in both Medicare Part D and in the Medicare Advantage plans, if you attract somebody into your plan who's 65 and healthy, that's great, but Medicare is going to pay you relatively less money. I mean, all the Medicare Advantage plans are getting paid well today. That's another related topic that I'm happy to talk about, but relatively less money if you attract and keep somebody who's 65 and healthy. In contrast, if you attract and keep somebody who's 85 and has 4 chronic diseases or who has HIV/AIDS, Medicare will pay you 10, 12 times more. And there now are actually some plans, some private health plans in Medicare that are called special needs plans that are sort of the reverse of the traditional criticism of HMOs. These are plans that are only open to people with chronic illnesses. Why? Because they're offering a lot of services like disease management programs and nurse practitioners to provide personalized care that only make sense for someone who has high expected health care costs. For somebody who's perfectly healthy, you can give them a nurse and give them a lot of personalized attention. It's not going to lower their health care costs very much. And so these are plans that are specializing and say that healthy people need not apply. So this can be done. It's just a matter of setting up the policies in a way that directly takes on the problem. So those are at least two changes from what happened 15 years ago that I think could make a big difference today. Yeah.
Bill Clinton was here in December stumping for Hillary, and he mentioned in one of his speeches that by applying an electronic medical record, that would cover the cost of Hillary's plan and make coverage so much closer to universal. And I'm interested in kind of the applicability of that. Was that just rhetoric, or is that?
Well, no, that's what I said earlier. So you're going to hear that from every single one of the candidates. They want to get to universal care. They don't, universal health care coverage. They don't have the money to pay for it in the current system. So they have to start talking about things like quality improvement and preventing errors and disease prevention and electronic health records. I think my main comment on that would be, again, you still get what you pay for. There's been a lot of proposals to just add in to our current Medicare payment systems or Medicaid payment systems, additional payments for electronic records. And I worry that unless we get the fundamental payment system right, that just doing everything electronically isn't going to necessarily save us money. You heard a few minutes ago about how a lot of doctors now have strong financial pressures to buy a CT scanner of their own. Well, if we did this, they'd have strong financial pressures to buy an electronic health record system of their own. Is that by itself going to lead to better coordination of care? Well, maybe, but probably not nearly as much much as if we were doing something like these medical home payments that I talked about earlier, where not only can you have financial support for the electronic records, but you actually get paid better when you take steps to keep your patients well and to keep their overall costs down. I think just adding in payments for electronic records to our current payment system, which doesn't provide very strong support for steps to keep people well and coordinate their care well, by itself probably isn't going to save a lot of money.
Hi. Thank you for coming. You can pretty much answer this question if I'm misinformed, but I've heard in the past that there's a lot of fraud going on between the financial transactions and insurers and doctors, and that I've heard up to 30%. Now, I know a way to tackle that would be to have this regulation and oversight of doctors, and I know doctors wouldn't be very pleased about that. How would you have an oversight? We've talked about databases, and this question is very much related to the CT scans. How could you have an oversight where that would regulate that without, encroaching on the doctor's boundaries, if that makes sense?
Well, I mean, you could just go to, the sort of standard rules and enforcement regimes. If you just make the penalty big enough, if we just shoot the doctor when they're found guilty of doing this, they'll all probably stop doing it. But we probably won't go to that extreme either. I think the actual numbers of fraud, in all seriousness, are a bit lower than what you said, but they're up there. In Medicare, when I started in the program in 2004, we had about 10% of our payments that we thought were inappropriate, either fraud or abuse, or it could be just very poorly documented care, but it's just stuff that looks like on paper didn't add up, didn't look remotely like the right treatments for a patient. And there are steps that you can take through better data systems as we're getting towards more electronic health care and better monitoring systems. By Medicare, one of the problems in government-run programs like Medicare is we have I think too little money spent on administration. Our administrative costs are about 3%, and that's too low because we don't have enough people going back and checking on inappropriate billing, and so we do see a lot of these potentially fraudulent services. So there are steps that you can take to try to reduce fraud incrementally, but it does require some kind of better investment in better data systems, better monitoring, or going to stronger penalties. A lot of the problem in healthcare, though, and where the number I think is 30% or higher, is in the use of services that are at best questionable and probably don't have any benefit for the patient. They're not out and out fraud, but these are areas where we don't know that a treatment works or not, but why not go ahead and try it, or where lab tests are ordered or imaging is done that may not be very harmful or very risky in itself, though every medical procedure carries some risk, and maybe it tells you a little bit more information, but it's probably not really worth anything. A lot of that goes on, and that's, I think, a direct consequence of the way that the financial payment systems work in healthcare. Again, when you pay based on volume and intensity, that's what you're going to get. So a lot of variations and a lot of potentially inappropriate care. And the steps that I was talking about earlier to try to do a better job of measuring quality, measuring the impact on care, and then paying based on that, I think could indirectly help significantly with fraud and then this much bigger problem of potentially wasteful or inappropriate services. Okay.
I'm interested in your comments about mental health services, particularly as they apply to drug and alcohol problems, because it seems like there's a big bang for the buck in prevention there and in treatment there as far as cost to society. Yeah. And outcome analysis is more difficult. Access is really problematic. Quality assessment is really difficult in the current system, and interested in your thoughts.
Yeah, those points are all true. Everything I said about the importance of measuring outcomes and measuring costs, and I said that there are challenges along the way, but we're making real progress. Well, in these kinds of mental health services outcomes, those problems are even bigger, and they go. A lot of these cost savings occur not in our healthcare system, but in other parts of society. Our government assistance costs, our prison systems, and so forth. And we're not even close to being able to measure those kinds of outcomes very effectively or systematically. My hope is that over time, as we do a better job of measuring outcomes within the healthcare sphere, that we'll be able to extend these same kinds of principles more broadly. In the meantime, there have been, I think as you implied, a number of innovative approaches to providing mental health services that clearly show beneficial results. And just because we don't have good outcome measures inside healthcare doesn't mean we shouldn't support good policy for other reasons as well. And where we do have evidence that some of these kinds of mental health services can lead to better outcomes for individuals and lead to other savings in government programs and other benefits for society, those are certainly good arguments on their face for why we should support those kinds of programs.
I'm sure we could keep you here all evening, Dr. McClellan, but we'll have one more question.
Okay.
Hi, I'd just like to ask what your opinion would be. You're saying that we need more primary care, we need more preventative care. We don't have enough supply in this country of physicians
because
who
we're not
provide
paying for
because
that.
we're not paying for it, and
volume and
people are
intensity,
graduating
yeah.
medical school and going into fields that will be able to pay off their $200,000 of loans.
Sure.
How do you have any ideas on how that can change?
There are a number of ideas for reforming graduate medical education, and I tend to come at this, as I told you, I went to graduate school with Andrew, so I come at this from a perspective of an economist as well. And I haven't really talked about it tonight, but the way that the federal government supports graduate medical education in this country is actually very much in line with what I talked about for how the federal government supports the overall direction of healthcare delivery, which is towards more volume and intensity. Just like the Medicare payment system based on fee-for-service and based on paying more for more and more intensive services was set up in the mid-1960s, and that's the way kind of insurance was then, private insurance was then, and it hasn't kept pace. Same thing with our system for paying for graduate medical education. That was set up in the 1960s as well, and back then medical education, like most of medical care, was hospital-based. It wasn't centered on the patient. It wasn't about integrated delivery systems. It was about spending all day and all night on the wards. And that's still how we subsidize graduate medical education in this country. It's based on your intern and resident to bed ratio and kind of how many interns you're serving in the hospital. And we tried really hard while I was at CMS to push as hard as we could to move away from that under current law. But it's awfully difficult when the plain language in the statute says that the payments to the teaching hospitals are tied to how many residents they're training in the inpatient hospital setting. So some things that we could do to help with this are, number one, make the kinds of changes in reimbursement and support for real efficiency and value in healthcare delivery that I was talking about today. If we have payment systems that reward and support doctors who find better ways to keep people healthy and keep them out of the hospital, like a good primary care doctors are trying to do today, I think you'll see over time more people gravitating into primary care. And not only more physicians, but a lot of the health care that's being provided for this kind of basic coordination of care is increasingly being done by people other than physicians, by nurse practitioners, by other non-traditional healthcare providers in non-traditional kinds of healthcare settings. And that's great. We need more of that if it's lower cost and it delivers better results to augment this diminishing number of primary care physicians. And second is reforms in the way that we finance graduate medical education in this country. And this has been a very hard topic to tackle because, frankly, the medical education community, the teaching hospitals and major medical centers in this country are very nervous that if Congress goes in and opens up the way that they finance graduate medical education, they won't just get a reform system, they'll get a system with a lot less financial support in the end. So it's been a very difficult process to open up. But again, the pressure is building because we're getting more and more disconnected between the way that our payment systems are working and the way that healthcare needs to work. And sooner or later, I think there will be kind of a reckoning for academic medical centers where we will find a way forward to refinance medical education and provide much better support for what many of the medical centers are trying to do now to get to more innovative ways of training physicians for the 21st century, for coordinated care, for non-traditional kinds of delivery systems and the like. It's just it's something that they're doing in spite of, not because of, our financing mechanisms today. Well, thank you all very much. I hope you enjoyed your Valentine's evening. Thank you.